So it's 3 o'clock and they close the door, which means we're all trapped in here for a little bit, talking about EEG, I guess. Good afternoon, everybody. My name's Dr. David Milette. I am the director of the epilepsy program at Hogue Hospital in Newport Beach. It is the second epilepsy program in Southern California that I have started and still am involved with. When I completed my training at UCLA, I founded the epilepsy program at Rancho Los Amigos for LA County. So still heavily involved in organizing that epilepsy program to serve the Department of Health Services in LA. But about 5 years ago moved down to Orange County to essentially take charge of the epilepsy program at Hogue Hospital and provide epilepsy services for the St. Joe's Hogue Health Network. As many of you who, if you live in Orange County, know, there are a number of hospitals in our county that are loosely affiliated with one another, but Hogue is the only one in that network that has an epilepsy unit and an epilepsy program and is capable of doing epilepsy surgery. So I moved down here a few years ago. And this is what I do. About 90 to 95% of my practice is epilepsy, both inpatient and outpatient. I generally see adults and teens, some children selectively, but I also am the medical director and primary electroencephalographer, so I read the squiggles, for a company called EEG2Go. If many of you may be familiar with that company. Brad Levy, who's one of the co-directors of this event, is the president of that company, founded that company. So I work very closely with Brad, and I read quite a lot of EEGs, particularly in small children who have autism or suspected autism or autism and suspected epileptic seizures. So I have a lot of experience reading EEG, and this session I think is entitled Understanding Your EEG, and I'm here to answer any questions you have about EEG. So this is like an audience participation thing, so I'm gonna just open it up at the outset for questions that people may have about their own EEG or EEG in general. And then if there aren't any questions, I guess I can draw some squiggles on the board, but it would be better if the next half hour were really driven by questions or concerns that you guys may have. Yeah. Yeah, yeah. An overview about EEG? Sure. So I pause and laugh because I have a PhD in history of science, and an overview of EEG for me begins in the 1870s and goes into the mid-1950s, but that's probably not the kind of overview that you meant. So EEG stands for Electroencephalogram. And an EEG is essentially any recording of brainwave activity, electrical recording of brainwave activity. And there are many different types of EEG and different variables that are important to keep in mind regarding EEG. Probably the most important variable to keep in mind is the duration of the study. Brainwaves tend to have certain patterns to them, daytime patterns or awake patterns, patterns during sleep. Abnormalities such as epileptiform discharges tend to come out during sleep, so sleep becomes an important state of wakefulness, lack of wakefulness to capture during an EEG. So routine EEGs, as they're typically performed in the hospital setting, are about 20 minutes. That's for a patient who's an inpatient in the hospital. They've either had a seizure, there's a concern that that they've had or are having a seizure, and those routine EEGs, sometimes 20 minutes, are also done in the outpatient clinic. Those are essentially that for many years has been the bread and butter, and the vast majority, 90% or more of EEGs that were performed are short 20-minute studies performed in an outpatient clinic, in a physician's office or in the hospital. Over time, the electronics have become greatly improved. So recording the EEG, storing the data over prolonged periods of time has undergone a complete revolution with computers in the digital age. So nobody's unwinding reams of paper along the floor to look at brain waves. Now we can scroll through at the click of a mouse. And so it's become possible to record longer and longer periods of time in a routine setting. So when a patient comes to see me, for example, in the clinic for an epilepsy evaluation, I order a 45-minute EEG. I don't bother with anything short of 45 minutes. I think that gives you enough time for reasonable sampling, including a significant portion of sleep. And then, of course, you have overnight studies both in an ambulatory, in a home setting, as well as overnight studies in the hospital. So the duration of time that you record the EEG is probably the most important criteria, because longer studies tend to capture more sleep, and sleep tends to be an activating state for the abnormalities that you want to pick out, so that you can figure out what kind of epilepsy whether they have epilepsy, what kind of epilepsy they have, where their seizures are likely coming from. So beyond that, where the electrodes are located on the brain has been standardized. In fact, it's an international system that any registered EEG laboratory in the country uses and shares with almost every other lab in the world, so that we all know that FP2 is here and P3 is here and O1 is back here. So there's a consistent relationship from patient to patient and lab to lab in terms of where the electrodes are located. Some labs will use a cap to help figure out exactly where the electrodes need to be placed. Some will measure it out by hand, but there's essentially an agreed upon system. Now that's scalp EEG. Of course, now in the modern era, we perform a lot of epilepsy surgery, and we record a lot of EEG from perform a lot of what we call intracranial EEG, which is EEG that's recorded directly from the surface of the brain or from electrodes implanted deep within the brain. And that looks totally different. There's no muscle artifact when you're recording from deep inside the brain. So it's a complete sort of perspective change to go from reading EEG from the surface and then looking at EEG that's been recorded from inside the brain. So I don't know if that answers kind of the overview question. So yes. Yep. When you say it's up here, what do you mean? Yep. So your teeth are only grinding because your temporalis muscles and your masseter muscles, which are here and overlie the important temporal lobes of the brain, are contracting. So it's not actually the teeth that generate the artifact in the EEG that make it hard to read. It's the artifact, the noise created by the contraction of the muscles that are actually grinding the teeth, that interfere with often with our ability to interpret exactly what's happening in the temporal lobes. So there are common sources of artifact or noise when you're reading EEG. I have often told trainees the art of electroencephalography is learning to look past or through the 70% of what appears on the screen that has no relationship to the underlying brain waves. You have to ignore about 70% of what you typically see during a routine outpatient study to get at the 30% that's actually reflective of the underlying brain waves. So that's one of the reasons that sleep becomes a very important state to capture, because generally, I mean, yes, people do have bruxism or teeth grinding in sleep, but generally it's less often during sleep than it is during wakefulness. So, yes, please.
So, if the seizure happened during sleep or falling to sleep, the EEG was done just the standard, like 20 minutes, sleep deprived, still didn't fall asleep, so they didn't capture any sleep, and hasn't been repeated. How do you know that your normal EEG is giving you any information? And how frequently should they have tried to repeat that?
So the number of times that you repeat an EEG has a lot to do with should have everything to do with the patient, and nothing to do with the practice, overhead, reassurance that you're not missing anything by doing an EEG every 6 months or every year. When patients are seizure-free, and we have a good baseline EEG, you don't need to repeat it. You don't need to, in my mind, you don't need to ever repeat the EEG if patients are seizure-free and doing well. When patients begin to have breakthrough seizures, or they've never been well controlled, or they're having side effects, and you think that maybe those side effects are related to underlying activity, or they have new symptoms, for example, memory problems, for example, or they've had something else happen to them. They've had a seizure and fallen. They've had a traumatic brain injury. Those are all good reasons to repeat the EEG. And in a patient who is not currently well controlled, a 20-minute EEG gives me no pause for reassurance. I'm not reassured at all that EEG is normal or that the patient is doing okay. I have every year we take probably 2 or 3 patients to epilepsy surgery that have normal EEGs. The EEG has some important limitations because only about 15% of the cortex is visible to the EEG that's recorded from the surface of the scalp. You have to have about 6 to 10 square centimeters of cortex involved in creating one of those sparks or discharges for us to be able to pick it up on the surface of the head. Okay? So if it's smaller than that, if it's deeper, if it's oriented, are there pens? Did somebody take the last dry erase pen? Can we get a dry erase pen? Thank you. So I'll draw this, but if this is the skull or the cranium that we record the EEG, you have convolutions, gyri and sulci of the brain that lie under that. And if the electrical abnormality is coming from the surface, you'll pick it up. If it's oriented vertically towards the scalp, you'll pick it up. If you're dealing with one of the convolutions that dive down in curves, and the EEG is coming from what we call the depths of the sulcus, so the crevice that goes down and the abnormalities down at the base of that. The electrical discharge, for the purposes of this, illustration, is horizontal. It's parallel to the surface of the head. So if if this is the scalp, your EEG electrode is sitting on top of it, and you have an area that's generating the discharges and those discharges are oriented in this position, and all electrical discharges have a positive and a negative, and they have a direction, what we call a dipole. If that dipole is oriented parallel to the surface of the head, the scalp electrodes don't pick it up at all. And that's where knowing the limitations of the EEG become important, because there are other types of tests that are very sensitive to that kind of activity. And probably the most important test that we use for that is called an MEG, or magnetoencephalogram, because because of the physics that relate electricity and magnetism, those magnetic detectors, not electrical now, but magnetic detectors, are exquisitely sensitive to discharges that go the other way. And so it's important to know, even for patients who, for example, they've been admitted to hospital, we've captured EEGs, we've captured seizures, we're not seeing a lot of discharges in between the seizures. There's not a really clear pattern of buildup for the seizure. That doesn't mean that you can stop. It doesn't mean that there's nothing else to do. It just means that the tools that you've deployed thus far aren't up to the task. They're not good enough. And you've got to keep searching for a better tool, usually an imaging tool like MEG, or there's another form of what we call source localization that does use very tiny signals in the EEG, called Eeg Source Localization, or other types of imaging studies. So a 20-minute EEG, even when you've so to speak captured the seizure, if it's normal, is not very reassuring if patients are still having seizures.
So the response that the readout was normal, so there was no seizure waves
Mm-hmm.
detected, and no sleep. The tonic-clonic happened
Yep.
in sleep. So and at the time we didn't have any abnormal MRI, which we do now.
Yep.
I guess that my question was, would it not necessarily be helpful to do a longer MRI?
It might be very helpful. We don't really know, but it might be very helpful, yeah. Absolutely. So sleep becomes a very important, as I mentioned. So sleep is the most important state to capture during an EEG, because there's more synchronization in brainwave activity during sleep. So you're more likely to reach that threshold of 6 to 10 hertz, 6 to 10 square centimeters of cortex that is synchronized to the point where you can detect something on the surface of the scalp during sleep. It's also it's also a time when, for example, muscle artifact, the noise created by chewing or eye movements or any kind of muscle activity whatsoever tends to be minimized, because while you're in sleep, generally there's much less muscle artifact, and the eyes aren't moving, the lids aren't open, and so you don't see as much in the way of artifacts. So it's a clearer view of brain function when patients are asleep.
So would you have continued to try to capture that?
Yeah. Yes.
Is there a reason then, just to kind of what you're saying, why use the EEG if the MEG is that much better?
I won't say MEG is that much better. MEG gives you complementary information. It tells you what the EEG can't, but but most cases can be figured out with the EEG alone, and it is vastly more expensive to obtain an MEG. In fact, there's currently no functional MEG in all of Orange County or all of Los Angeles County. There's only one in San Diego and one in San Francisco in the state of California. So imagine having only 2 EEG machines in the whole state, right? That's not. So the patients that really need an MEG to make sense of their epilepsy for the purposes usually of planning surgical interventions are much, much, much smaller. There was a question there in the back. Yeah. Hi.
Can I read you one sentence off of an EEG's impression and you
Oh, as long as it's not mine. Yeah. Yeah, as long as it's not my EEG report. Yeah. Okay.
Abnormal 3-day ambulatory EEG reporting due to the reoccurrence of sharp waves over the frontal and temporal regions bilaterally and sometimes in more generalized fashion consistent with generalized seizure activity. I know. Try not having a PhD. What does that mean? I get it. She had a seizure. Got it.
No, it doesn't. It doesn't mean she had a seizure. So let's back up. So discharges, sharp waves, are somewhere between 70 and 200 milliseconds. Okay? So they're a fraction of a second long. The longest a sharp wave can be is a fifth of a second by technical definition. Seizures, unless it's a myoclonic jerk, which is also a fraction of a second, most seizures that we're concerned about, generalized tonic-clonic seizures, complex partial seizures with impaired awareness, they typically last a minute and a half, 2 minutes or longer, right? So those sharp waves are the sparks, not the fire, right? To use a crude analogy to seizure activity. And what it may tell you is the areas of the brain that are involved in a network of abnormal activity. That network may give rise to seizures, may not, but those aren't seizures. And this is a common misperception. I do have patients who schedule a consultation with me sheerly on the basis of this, right, I got your EEG report. They may not have even been my patient, but I happen to have read their EEG. And it's full of seizures. I'm having seizures every night. You're not having seizures every night, but there are these little bursts of synchronized electrical activity that are abnormal and that are likely to indicate the areas of the brain that are involved in, or potentially involved in seizure activity. It may also point to areas of the brain that are just having these little discharges and no seizures. We have patients that are seizure-free for years, typically on medications, who still have abnormal EEGs. They're not having seizures, but they do have abnormal EEGs. So it's a 3-day study. During that 3 days, they picked up sharp waves that were occurring in the left frontotemporal area, the right frontotemporal area, and sometimes it sounded like from what you read, they were happening synchronously that suggested some generalized activity. Generalized simply meaning both sides are involved at one time. I have made it a practice since I began reading EEG, in particular the ambulatory study reports like that, of putting pictures in every abnormal EEG report. You will not see, and I probably do 2,000 a year, you will not see an abnormal EEG report of mine without a picture of the abnormal brainwave activity, so that when, so that patient can go to any other epilepsy specialist and they will understand exactly what I'm talking about. Because you just illustrated a very common problem, and that is that, the words, it takes a little time to decipher them, even for an expert. And what the actual squiggles tell the expert and what those words say may be two different things. So, yes? Yes and no. Well, yes and no. So there is definitely an art to reading EEG, and the kinds of frontotemporal sharp waves that are described in that report may be normal in some patients. So there is an overlap between abnormal and epileptic and what we call normal variant. And it just takes a lot of experience reading EEG to be able to definitively say, given an EEG, whether that's normal or that's abnormal. And there are still patients that I will walk the line. I will say, I think this is normal, but in some cases it may represent an abnormal epileptiform variant. But most of the time you can tease them apart. It sounds like from whoever wrote that report, and the who wrote that report becomes really important, as in terms of the context of what I just said. Experience really matters. Is that someone who just finished their 1-year clinical neurophysiology fellowship, where they got 3 months of EEG and 3 months of EMU and 3 months of doing nerve conduction studies, and now they're in private practice? Or is that somebody that did a dedicated 2-year epilepsy and EEG fellowship, in an epilepsy center that probably saw, 5,000 EEGs, with very guided reading during their training, and now has been out in practice for 10 years doing it day in and day out? That report coming from those two different individuals means very different things.
So if the spark is 70 to 200,
Milliseconds, fraction of a second.
by comparison, what is considered an epileptic?
This is that would. It's not the duration. So you can have a sharp and slow wave complex, or so spikes are less than 70 milliseconds, right? But these are sharp waves. These are sharps, if you see that, and technically spikes are less than 70 milliseconds. So the old guard used to say a spike is something that, if you can imagine, you step on it and it hurts. So a spike is like this. Spike in a slow wave can be like this. A sharp looks like this, and a sharp in a slow wave looks like this. It's probably a bad drawing of a sharp and a slow wave complex, but in any event. So the sharp component is generally the classic epileptiform, or excitatory portion of that indicates a hyperexcitatory state of that network. Correct. There was a question. I'm sorry. Yep.
We're modeling a lot of myoclonic and absence seizure type stuff.
Okay.
Multiple EEGs over multiple days. Both of which come back as non-epileptic seizures, or non-epileptic myoclonic absence.
Okay.
Is that something that could be misread or missed, or maybe something we can look into in EEG? It's not available in the sort of we've done, like I said, we've done 2 EEGs over 6 days for one, over 3 or 4 days for a second one.
With a lot of myoclonic activity.
And they have video of myoclonic
Uh-huh.
jerks. They have video for the 6 days.
Okay.
So they see the jerk, they don't see
The EEG discharge. Yep. Yep. So this is tricky. Myoclonus can be cortical, can come from the cerebral cortex. That's generally epileptic, and we see a discharge on the EEG coinciding with the jerk, right? Myoclonus can also be subcortical, which is it's generated by nuclei that are deeper in the brain. And we don't often or ever see the discharge on the scalp with those episodes of myoclonus. That type of myoclonus you can see, for example, in patients that have myoclonus related to drug exposure. Some people don't tolerate opiates, for example. They get morphine for something and they start jerking, right? But there are a lot of causes, and a lot of different medications can lead people to have myoclonus. And that subcortical myoclonus doesn't have an EEG correlate, and it's not considered to be epileptic in the traditional sense. So it really kind of gets into the details of how sure are they that that's myoclonus, how sure are they that the EEG is truly normal during that moment, and what do the basal ganglia look like, what do the thalami look like, what do the other deep structures look like, and is there something else that might explain the myoclonus besides epilepsy, right? So is there a congenital problem? Was there a hypoxia or anoxia? Was there during early life, was there was the brain deprived of oxygen, and we're dealing with a deeper nuclei problem? It really becomes probably imaging becomes the most important piece of it, and then finding presumably a child neurologist or pediatric epileptologist that can understands different forms of myoclonus and how to treat it. So, and then some of it may just be behavioral, not myoclonus at all. And sometimes you need actually an EMG to kind of a muscle electrode to confirm that it's truly myoclonus and not volitional movement of some kind. It can get complicated. So, yeah. Yeah. Other questions? Yeah, in the back, please.
So my daughter, she's 15, she has prolonged focal seizures.
Okay.
And right-sided hyperemesis due to restricted Neuro.
Okay.
So that is where the unfortunate activity originates. When we go for EEGs, we do the 20-minute outpatient EEG. The doctor reads it, comes back and says, yep, we still see spikes and sharp. Well, we see sharp to slow. So thank you for the visual. I appreciate that.
Yeah.
I can't read one. Yes, we still see that. Although she's been seizure-free, knock on wood, for 5 years. No, we still see it, so she's got to be on medicine. At that point in time, I mean, I understand she will always have
Yep.
these.
Yep.
What should we do? I mean, it's been a long time.
It's a great question. And I'm going to generalize it to make it not specific to your. I'll address it for your daughter, but I think the general question is, what is the significance of an abnormal EEG for a patient that has not had a clinical seizure in a long time? Okay, and with regards to medications, right? What are we doing with the medications? Do we still need them? Which becomes the yeah. And sometimes, patients and families don't want to come off because they don't want the risk, right? But sometimes they do, or the teen who's now 18 or 19 and going off to college, like, do I really have to? I haven't had a seizure in 10 years, kind of situation.
Take her off because she's getting older. Let's see while we monitor what meds she's taking.
Yep.
Should we take her off? What happens?
Yep. So then it becomes, you have to get into some of the details. So number one is, it's important what the underlying etiology or cause is. In your daughter's case, where you're dealing with a structural lesion, this is a perinatal stroke or early life stroke. There's scarring. That scarring is never probably going to go away, and will always be a source of irritation to the normal brain. That is a situation where we knock on wood that seizures are well controlled. We try to find a combination of medications that both controls the seizure and does not introduce side effects, intolerable side effects, and we essentially continue indefinitely. because there's a very high risk of seizure recurrence if you take away the medication. There are other kinds of scenarios, however. For example, some of the genetic epilepsies, like juvenile myoclonic epilepsy, where the brain MRI is normal, EEG is abnormal, patients have had a handful of seizures. In that case, we have the myoclonic jerks often, plus the generalized tonic-clonic seizures, where you may have had seizure control for a number of years and consider coming off the medications. And in that patient population with that type of epilepsy, there's about a 30% chance of coming off of the medications and not having a seizure. And we know this from patients that actually took their own that self-discontinued medications. So nobody got an EEG and said, your EEG's clean, take off the medications. They just figured it's been 10, 15 years, 20 years, I'm going to take myself off. About a third of those patients do fine. They don't have another seizure during the period that they've been followed up, which is a number of years. The rule 10 years ago was, for that type of epilepsy, you're on medications for life. Now we know differently, that some patients choose to come off of medications and do all right. And we suspect that in a fair number of them, they're still going to have abnormal EEGs. Do you necessarily put them back on medications?
She continues to have these abnormal EEGs
Yeah.
due to a structural.
Yeah. She always will.
She always will have them. But is it something that would warrant an overnight 3-day like EEG to find out?
Not in my book. Not in my book. Yeah. Yeah. In my book, if she's been seizure-free, how long has she been seizure-free?
Not on, well, 5 years. However, we're reducing we're weaning her off one medicine to see.
Yeah.
So maybe then reevaluate.
Yeah.
If we still think that the 20-minute EEG is something that's warranted, or should we go into a deeper,
Yeah.
a longer.
Yeah, so now we're introducing a lot of detail. So it's not just one medication, but it's how many medications is she on, 2 or 3?
She's on low dose tokenized.
Okay, so she's on 2 and you're getting rid of one of them. There are different opinions on the matter. And some people will want EEG guidance during this transition, take her off of it and see whether she has more spikes. But we all know that some patients have a lot of spikes on a Monday and not very many spikes on a Wednesday. And the question is, are we going to make the decision about taking her off of medications or not based on an EEG? If they're young, if they're teenagers still under very close supervision, not driving, I would go ahead and try to reduce the medications to the extent that you're comfortable doing so, almost regardless of what the EEG says, and then it becomes academic. But I respect the opinions of other people that really want to see the EEG both before and after, and in some cases I will also order it, or I'll wean them off in the hospital if I think they're at high risk for having seizures, not for having abnormal EEGs, but if I'm concerned somebody's very delicate in terms of their seizure control and nothing's working as an outpatient, and we bring them into the monitoring unit to make a lot of changes. We've done that. I've done that too. So it really depends on the circumstance. Are there other questions people have? Yes, please.
Do a hospital 5-day EEG. Do they make you off your medication? In the beginning, how do they do it? Quick? How does that work?
So there are general approach algorithms to doing this. It depends on the circumstance. But in general, if patients, the average patient, and there's no such thing, but the average patient who's having 3 to 5 seizures a month and is on 2 or 3 medications and you're considering surgery, I generally reduce the medications by 50% day 1 and another 50% day 2. So by day 3, they're on 25% of the medications they take at home. And then if that doesn't do it for another day, then we sleep deprive them. Some places sleep deprive them day 1. Pardon? We do what it takes, right? They're there for a reason. Yeah. 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 Yeah, we have a joke at our hospital because I do work at a very nice hospital. It overlooks the Newport Marina, and the epilepsy unit actually has a gorgeous view. It's got $1 million view, and I tell them they really should have put the monitoring unit in the basement with bars on the door to generate more stress so patients would have seizures more quickly. So they weren't thinking of that when they figured out where to put in the monitoring unit. But in any event, so that's, and there are differences. So in the medications too. So for example, phenobarbital, you can't, first of all, it has a long half-life. And second of all, you cannot abruptly discontinue or reduce it very aggressively because you'll have a withdrawal seizure. Zonisamide, you don't have withdrawal seizures, but it has a 60-hour half-life. So I know that if I wait till day 3 in the monitoring unit to get rid of the zonisamide, I'm not gonna, their body won't clear it until day 6 or 7, or at least significantly reduce the levels. So zonisamide is a good example of the one drug that I cut off on admission to the monitoring unit because I just know that that's going to stick around for a long time. So, any other questions? EEG? Anything? Yes. Go ahead. Uh-huh. Yeah. Okay.
Do you have advice for us on how to deal with it in the hospital for 3 days?
Oh, in the hospital? You're going into the hospital for it? Okay.
For 3 days with her.
Uh-huh.
She hasn't been in the seizures, or said that she's been in the hospital since she was in the ICU for all her seizures. So advice would be great.
She doesn't remember that.
Movies, iPads, games, just entertainment. It is, even for the most mature and compliant patient, 3 days chained to a bed is a long time. It's a long time. Yep. So just try to make it easy for her.
Okay, thank you.
Please.
Is there any relationship of the activity at nighttime while during sleep related to fatalities during sleep?
So SUDEP, you're asking me about SUDEP and whether or not epileptiform discharges during. I don't think that's ever been looked at. Certainly the timing of the seizures themselves has been looked at, but there isn't necessarily a close relationship between even the frequency of the discharges and the occurrence of the seizures. You would care much more that a patient's having seizures from sleep than if a patient's having a lot of discharges in sleep. But the part of the problem is that for the EEG can change over time, and we don't. Unfortunately, we don't have retrospective EEGs within a month of all cases of SUDEP. So it would be a challenging type of study to do with a lot of variables that would make it difficult to come to a conclusion, even if you saw a trend. So yes, please.
I know there's no substitute for experience. So can you suggest some technical literature that a person might be able to obtain in order to understand an EEG waveform?
There are a number of books and websites and
Producers, any special ones come to mind?
there have been a number of them over the years. I actually contributed to a couple of them. One is John Stern's Atlas of EEG patterns, and also Atlas of video electroencephalography. How the EEG relates to seizures? Can you clarify your question? I mean, I guess I would consider the entire topic of today as being is falling under that category, how the EEG relates to seizures. It is a very complicated relationship. It's not a one-to-one relationship. And patients that can have, for example, generalized epilepsies can have focal discharges, and vice versa. Patients that have generalized discharges can have focal seizures. It really comes down to understanding epilepsy more so than just the EEG. EEG is just a tool. Without an understanding of the epilepsies, it's almost useless. Yes?
Other than electrode placement having sort of changed, is there like technological advancement that helps the EEG become a better tool in helping us understand the more the whole picture of that particular patient's epilepsy, so that they know kind of maybe what their couple best options
Mm.
would be. You know, I mean, maybe they could stay on medication for the rest of their life because they found something on the MRI and they're able to manage it okay. Or maybe if an EEG is a good enough tool, they could decide if they want to try to come off because the EEG is showing.
Kind of, I'll revert to, I guess, the last response I had, which is that the EEG is just a tool, and it will always be just a tool. It can be a very useful tool for a variety of different questions. What type of epilepsy, what type of seizures, where are they coming from? Are they a surgical candidate? Are some of their cognitive symptoms related to abnormal electrical activity in the brain? Are there anti-epileptic medications I should avoid in this patient? I mean, the EEG is good at helping to answer all of those questions, but it doesn't point to the answer in a vacuum. It's not.
Right. So they'll like MRIs have gotten more powerful or whatever, and they're able to
Yep.
produce a
Yes, I understand your question a little bit better now. So the major technical limitation about EEG is skin, bone, muscle, connective tissue, blood, right? All the things that separate the brain from the electrodes, that filters out a lot of what you would otherwise really very much like to see, that's high frequency, low voltage activity, probably pathological. So I'll take that example. So there are types of EEG patterns called high frequency oscillations, or HFOs, that have become, that were all the rage about 5 to 10 years ago in EEG. There's still quite a lot of research going on about them. They're very, very fast. They're on the order of 200 hertz. So you can't see them on a typical 10-second page. You need to be sampling at a very high, 5,000 kilohertz sampling rate on your tool, and you need a computer to search for those oscillations within the context of an EEG. But the problem is that most of those never make it out to the surface of the head. You can only really record them from direct brain recordings. Correct. Now, having said that, in 2019, we do have a device that we are using more and more frequently that does routinely record brainwave activity, which is the RNS. So the RNS device is an implanted device that records brainwave activity we teach it to recognize a seizure and to deliver a current, like a defibrillator, to stop the seizure. And so we do have now many hundreds, maybe thousands of patients that are walking around with devices, implanted devices, and we might be able to pull out high-frequency oscillations from them. But that's not a routine scalp EEG. There are some patients that have thin skulls, not much tissue outside the skull, who they have been able to record high-frequency oscillations with an EEG, but that's not your typical patient. And then the MEG, the magnetoencephalogram, is able to pick up those high-frequency oscillations in some patients with very specific type of look. But for the routine, the kind of the regular old EEG that everybody's walking around with reports on, and we're hooking patients up and taking them down and doing them in the hospital and at home and 20 minutes and 45 minutes. It's about as good as it's going to get because of the intrinsic limitations of recording brainwave activity from the surface of the scalp, which in and of itself is a miracle, right? It took a deranged psychiatrist who believed in psychic energy 40 years to discover that one could do what we now do routinely. It was not the product of rigorous scientific testing. It was a matter of passion.
I wonder why we're still bothering to do the 20 minutes. Because it seems anybody that's really sort of has a better understanding of how all of this fits together.
Yep.
Orders 45 minutes.
Yep, or longer.
Are we talking insurance?
I don't know. Comfort level, old school versus new school. I don't know. Apparatus. I don't know. You can do a lot. I mean, MRIs. There's a lot of work that goes into getting the most number of images in the shortest period of time in the magnet, because magnet time is money. If you can reduce that time of one MRI by even 3 or 4 minutes over the course of a day, you can scan 2 more people, right? And so EEG is the same way. If the 20 minutes normal, they can send them off to an epilepsy center. They can deal with the rest. So. Are there any other questions? I'm kind of involved in the medical education activities upstairs, so I'm happy to take any more questions, but I have to go up and finish organizing the doctor lectures. Does anybody have any other questions on EEG today? Okay. Well, enjoy the expo. Look forward to seeing you all around.